So hello, everyone. Happy lunch hour. Thank you for joining us during your lunch. We love cameras on, but we totally understand it if you want to have cameras off and eat lunch. We have been so excited about doing this presentation now for quite a while. Really kind of the CalAIM basics and path basics. So for today, we're going to outline DHCS's commitment to improving the health and well-being of Medi-Cal members through a variety of initiatives, and then kind of look at what's the overarching structure of CalAIM. And I'm hoping that by the end of today, it doesn't feel like this big, huge, hairy beast, like this kind of nebulous, I have no idea what CalAIM is, because I think it's actually simpler than we make it. So we're going to break it down. And then as we talk about CalAIM, I think we forget about the A and the I in the acronym, and it's about advancing and innovating Medi-Cal. And I think the innovating part is hard, and we're slowly getting to it. We'll talk more about that on day 3. Tomorrow, we'll further define what the role of the PATH collaboratives is/are, that's part of PATH. We'll dive into some of the details around enhanced care management and community supports. And then as we kind of put in our blurb about this whole series, we really want to think about how the CalAIM programs and ECM and community supports fit into our community, thinking about, for example, and we'll pick this up on day 3, really thinking about how the role of primary care, which is kind of the bedrock of the healthcare system, healthcare delivery system. And we have thought about very closely some key leverage points and opportunities in Santa Cruz County, especially to reach those members that may be unseen or unknown, and really think about, like, can we really dig deep and think about that, advancing and innovating how we deliver healthcare services in ways that work for everyone. I think I'm most excited about day 3, but let's sally forth with day 1. This is the PATH team. There's 4 of us, our small and mighty team. So Berenice is on the line. She's our operations and program manager. Maria Estella, Gerizano, who keeps us straight. Maritza Lara, our executive director, she plays an important role on our team because she kind of knows all the players in Santa Cruz County, and people go to her and they say, well, what's this PATH stuff all about? And she connects us with folks who are either doing community supports or ECM, or are kind of what we call kind of CalAIM PATH adjacent. And so through her, we have been able to make some really great connections and advance some people towards community supports and or ECM. And we love that we are a trusted advisor in Santa Cruz County and beyond. Sometimes I wonder whether we should drop the Santa Cruz County part, because we're not just here in Santa Cruz County. And we are deeply connected to our local community, and we've worked with so many partners in Santa Cruz County, and our reputation is that we make things happen, and we just love that about us. So a couple of little bits and pieces, orientation and acknowledgement. So if anything is underlined in the slides, it's a link to a resource. We will be sending out a PDF and a link to the full set of slides when we send the recordings, which may not happen until maybe December 11th, once we chop out any dead space areas or any errors. And then we've really tried to describe all the acronyms, because if you're going to be talking about CalAIM and Medi-Cal all together, it's just an acronym salad. So we've really tried hard to make sure we don't have any undescribed acronyms. And if we missed one, let us know. So our first 2 slides do have some undefined acronyms. Chat or raise your hand at any time if you have questions. It's a lot. It's just a lot. And as we were putting these slides together, we thought, goodness gracious, like we're just, it's just a lot of words on the slides. And I am My graphic design skills, quite honestly, are about a second grade level. So they are wordy slides without really interesting icons and pictures. Forgive us in advance for that. And Medi-Cal, CalAIM, it's just a lot to get your arms around. And you may have heard that to learn something, you need to hear it 7 times and in 7 different ways. For me, I think it's, more like 14 or 15. But hopefully this will be one of the times. And then if we have any information that is incorrect or misleading, please put it in the chat, because what we're learning out there here. And we had great aspirations of, oh my gosh, if we put all this information together, folks can use our slides to do their own trainings. Okay, so that might be a little bit lofty. It's hard to take somebody else's slides, but we will say that if imitation is the sincerest form of flattery and you take our slides and use them, we would love that. And that's why we would like to get you the original sets of the slides if you can take them and use them. So Medi-Cal transformation. So Medi-Cal transformation has been underway already for many years, many years. Anyone who is anywhere close to Medi-Cal or serving Medi-Cal members, Medi-Cal, of course, is the kind of the name for California Medicaid. The big picture. So as Medi-Cal has transformed, kind of trying to keep up with all of the changes, is really thinking about access to new and improved services. So access to new and improved services sounds like just a really, it's just a few words, but they are truly innovating and creating new services and improving the services that are already in place. So for example, the CHW benefit, new Medi-Cal benefit for Medi-Cal members, doula services. There's just so much. And it's truly to get a well-rounded care that kind of goes beyond the outpatient offices, hospitals. I think about people coming to primary care or maybe going to specialist offices. But when you add up the time, let's say maybe that's 2 days out of the year, right? So the other 363 days out of the year, people dealing with acute, chronic, or urgent conditions are pretty much on their own. And so Medi-Cal is really seeking to create kind of a network or set of services that go beyond, that kind of cover people during those 363 days out of the year. If you add up the hours, it's almost 9,000 hours that we expect patients to just be on their own. And then to address all physical and mental health needs. That's a bold and audacious kind of statement or goal. I mean, that's huge. And then to have the care coordinated, person-centered, which quite honestly, person-centered can be a lot. So it's patients, families, caregivers, and equitable. Health equity is, as you know, is quite the buzzword these days. And then to continue to drive quality of care improvements. So you may remember that we did the PATH series around the model for improvement. Continuous and relentless improvement, streamlining. We had a listening session with Santa Cruz Community Health today, and they used the word streamline, like streamlining things, reducing complexity. And I really think about this as hitting the easy button for patients or members. I'll just say that patients is not the preferred term, but we still continue to use it because it seems to be the easiest. I'll try to use the terminology member or beneficiary. And then equity focused. We have a lot of work to do around ensuring that the healthcare services that we deliver are equity focused, data driven, and whole person. Sometimes when we think about whole person, so it's really about people's health and well-being. And in primary care, we often call this Another term we use is womb to tomb, so over the lifespan of individuals. So we just kind of covered kind of the big picture, the very specific goals of Medi-Cal transformation. And think about this as the big umbrella under which CalAIM is. There's a bunch of other things under the umbrella of Medi-Cal transformation, but the goals are, and you're going to hear this probably repeated at least 3, maybe 4 times, but addressing physical and mental health needs. So ensuring that the healthcare services that we deliver are comprehensive, and they include preventive care and personalized care. And thinking about how you operationalize that can, hopefully we can talk a little bit about, touch on that on day 3, but strengthening and integrating mental and substance use disorder services. So when you think about primary care, yes, it's the bedrock of the healthcare service delivery system. And we have 3 federally qualified health centers in Santa Cruz County. So we have Santa Cruz Community Health, we have Salud para la Gente, and we have our county clinics. And those types of clinics, community health centers, work really, really hard at integrating healthcare services all together. So integrated behavioral health. So they have behavioral health specialists. So if you're seeing someone in the clinic for, primary care clinical services, if somebody has a behavioral health need, you can do a warm handoff to an actual person if needed. And address health-related social needs. So this is a term that DHCS uses, health-related social needs. And I think, we often think about this as social determinants or drivers of health, and it is community supports that is really kind of identifying and addressing those health-related social needs. Improving and integrating care for Californians. So there are several initiatives, including those under the CalAIM waiver. And if you don't know what the CalAIM waiver is, it is a way for Medicaid state agencies to signal to the Centers for Medicare and Medicaid Services, or CMS, hey, we want to do things a little bit differently, or here's what we're planning over the next 5 years. And I've taken a peek at the CalAIM waiver and other waivers submitted by Medi-Cal. They are comprehensive and very well laid out. And then integrating and coordinating care. I'll just say, any of you who have tried to intersect with healthcare, which it's got to be everybody on this call. I mean, how frustrating it is. It currently is just not integrated, and it is not coordinated, even with our ECM and community supports providers. We've heard from our ECM providers. I have no idea what community supports our members are receiving. We have opportunities there. I mean, that's a little one. We just are sometimes really egregious with integrating and coordinating care. And then expanding, being a catalyst for equity and justice. And beginning January 1, 2024, there's a new law in California that allows adults ages 26 through 49 to qualify for full scope Medi-Cal, regardless of their immigration status. And of course, all the other Medi-Cal eligibility rules apply, but it's called the ages 26 through 49 adult full scope Medi-Cal expansion. And to me, this is huge. And I really feel that Medi-Cal and the state of California is way ahead of the curve when it comes to serving the residents of their state. So that goal of being a catalyst for equity and justice, so expanding services to address racial and ethnic disparities, committing to building a healthier and more equitable state for all Californians, regardless of ethnicity, gender, sexual orientation, disability, age, immigration status, health needs, or where they live. So for us to actually do that, we need to start collecting that data. So, for community supports, if we look at are there ethnicity, gender, age, disability differences that can be addressed so that we are ensuring that we are having an equitable state for all Californians, and then working together. So leveraging the broad network of partners, including our health plans, which for us are now Kaiser and the Central California Alliance for Health in Santa Cruz County, providers, community-based organizations. And I actually think it's bigger than that. So I think we really need to double down on like, what is that broad network? And the Path Collaborative has really been thinking about like, hey, why aren't we including, I don't know, faith-based organizations or barbershops or nail salons, or really taking things to the street, maybe doing street medicine. So I think that it's the broad network of partners is pretty broad, and we need to, if we truly are going to be innovating, we need to think about who's actually in that network. So, how I said that there's Medi-Cal transformation is like a big umbrella. Okay, so all these things on this slide are included under that umbrella, really working for that broad goal of coordinated, person-centered, and equitable healthcare system delivery that works for everyone. And the ones that kind of fit under CalAIM are our CalAIM adjacent, our community supports, the ones with asterisks, community supports, ECM. The incentive payment program is kind of included in that. The justice involved initiative is kind of under PATH. And so we're really going to focus on, over the next 3 days, community supports, ECM, and PATH. But just so you can appreciate that there's a ton of initiatives going on to reach the goals, and there is an immense amount of money behind this as well. So CalAIM, big picture. So we had that big umbrella, and now we're going to kind of a smaller subset of Medi-Cal transformation, and that is CalAIM. And CalAIM is very specific, kind of there's the big picture, but it addresses specific complex challenges like unhoused, unsheltered. As you know, community supports, big part of community supports tackles the unhoused and unsheltered. Insufficient behavioral healthcare access. So when we were working on referrals for people who screen positive for adverse childhood experiences and are experiencing toxic stress, there was a 30 to 60 day, sometimes even 90-day waiting period to get individuals into behavioral health care. It's just, honestly, it is heart-wrenching to hear some patients' stories. So even if you're not, so toxic stress has been going on for a while, but for acute issues, there's just not the access. Hopefully that will improve. Youth with complex medical conditions, they are part of the populations of focus. Justice-involved individuals, again, they are part of the population of focus. We'll dive into that a little bit more. People who are getting older and people who are living with disabilities. So those are kind of under that one, addressing many of the complex challenges, applying non-clinical interventions focused on whole person approach. And this is, targeting those social drivers of health, or the health-related social needs, that other term that is kind of used very closely with social drivers of health or social determinants of health. I think people are kind of steering away from using the term social determinants of health because it's, deterministic terminology, and it kind of implies that that's just the way it is. And social drivers, I like that term better because I feel like, okay, if we just turn the steering wheel, can we take a more positive road or path? And then reducing health disparities and inequities, of course. And then implementing broader system, program, and payment reform. So just embedded in that is those 3 words. So kind of changing the healthcare delivery system, having specific programs, which is what Medi-Cal has, and then reforming payment. So for some of our FQHCs, those 3 that I mentioned, changing some of the payments from what is called okay, I don't want your eyes to glaze over, but some of the payment models for our FQHCs from their prospective payment system to a fee-for-service system, which helps with revenue for our community health centers, and to take a population health approach, person-centered, to providing services and improve outcomes for all Californians. And you'll note that they're very specific in their terminology, and they kind of steer clear from saying providing care to people. So it's really about delivering healthcare services. Again, kind of steering clear of paternalistic terminology. Okay. So now we're I feel like it's a bunch of nesting dolls. We kind of are going into the smaller and smaller nesting dolls. So the PATH initiative, or providing access and transforming health. It's unfortunate that we have acronyms because, it's PATH. And we forget that it's really about access and transforming health. So, it's kind of like built into there, but it's 5 years and a ton of dinero. So it's a $1.85 billion investment to take Medi-Cal transformation to the next phase. It really builds on the successes and lessons learned from the whole person care and health homes pilot. So some of our ECM providers, for them to switch to start providing enhanced care management, they were already doing it a little bit or a lot under the whole person care. And so it's just kind of, we call it something different. There's kind of new guidelines and guardrails. But we kind of cut our teeth on whole person care and health homes pilot. And then the PATH initiative is really to build up the capacity and infrastructure of on-the-ground partners, and that's not just ECM and community supports providers, to successfully participate in the Medi-Cal delivery system and implement enhanced care management, community supports, and justice-involved services. So really think about those 3 as being part of PATH. I see something in chat. Will CalAIM and CalPATH have requirements for MCOs to be compliant with SB 1004 palliative care management? I am unsure. Arif, I know you might be able to respond to that, or I'm not sure. I can see your picture. I can't see if anyone from Central California Alliance is on, but that's kind of beyond the scope a little bit. Great question, however.
Yeah, I'm happy to quickly address it. So yeah, if the question is about palliative care, the requirements laid out in SB 1004, those are Medi-Cal requirements. And there's also a DHCS all plan letter, APL, as well. So all the managed care plans have to provide that benefit. So if that's the question, then the answer is yes.
Thank you, Arif.
Yeah.
So the PATH initiative goals, overarching goal is to build up capacity and infrastructure. And there's a lot of money behind that, building up the capacity and infrastructure, as we'll discuss, such as community-based organizations. The role of community-based organizations in providing services to residents of the county is just huge, cannot be understated. There's the public hospitals, county agencies, tribes, and others to successfully participate in the healthcare service delivery as California widely implements those 3 things again, right? Enhanced care management, community supports, and justice-involved services under CalAIM. And then identify and address the gaps in local organizational capacity and infrastructure that exist statewide. And honestly, I feel like we have some little gaps and some gaping gaps that hopefully with CalAIM and PATH and other Medi-Cal transformation efforts, we can start identifying and closing and really streamlining things for patients, just navigating the healthcare system for members beneficiaries is just daunting. And starting in 2024, for example, for Medicare beneficiaries, there's a new kind of benefit for actually navigating the healthcare system. So there are also 2 aligned programs that provide support for justice-involved capacity building, enhanced care management, and community support. So again, that's the 3rd time you're hearing that trio that is under PATH. So when you think about the PATH initiative, we can call it the CalAIM PATH initiative. There are 2 aligned programs and initiatives. So I think if there's 1 or 2 takeaways from today, is that CalAIM PATH initiative is not as complicated as it seems. I think when we first started working on PATH, I had this anxiety, like, I need to learn CalAIM. Like, what is CalAIM? I need to be able to explain it to people. And hopefully in the next few minutes or so, like, we'll break it down for you so it's digestible and it's not so intimidating. So 2 aligned programs and initiatives. So the Justice Involved Capacity Building Program, and then support for implementation of ECM and community supports. Again, that trio. Under the Justice Involved Capacity Building Program, we're going deeper into the nesting dolls, guys. There's collaborative planning and capacity and infrastructure. So there's those 2 parts. All right, hold on to your hat. Here are the pieces that are under support for implementation of ECM and community supports. The whole person care services in transition to managed care mitigation initiative. Funding ends January 2024. We're almost there. So we kind of don't need to worry about that one anymore. There's the Technical Assistance Initiative, and that's the TA Marketplace. Stay tuned, we'll talk about it more. There's the Collaborative Planning and Implementation Initiative. Hello, that's us, the PATH Collaboratives. And then the Cited Initiative, which is grant funding. We'll touch on that a little more in just a moment. So we're going to start with that one that you saw on the left-hand side of the screen, the Justice Involved Capacity Building Program. It started in 2023, and it's to support implementation of pre-release Medi-Cal enrollment and suspension processes, as well as the delivery of Medi-Cal services in the 90 days prior to release. So this is all about funding. There's funding to support several organizations and others so that they can jointly design, modify, and launch new processes aimed at increasing enrollment in Medi-Cal and continuous access to care for justice-involved youths and adults. So if someone is justice involved and they have not been released yet, how do you take them from being in the jail to being in the community and not have a break in the supportive services, especially around behavioral health? And there's quite a bit, if you kind of read a little more about justice involved, there's a requirement for behavioral health linking, for example, making sure that people don't fall through the cracks. And then there's this other piece for capacity and infrastructure, funding to support all the folks involved for capacity and infrastructure. So if somebody requires enhanced care management or community supports, how do you make sure that those are in place before somebody is released? And the volume of people who are released is, I'm pretty sure, if I remember correctly, it's about 400,000 per year. It's a lot of people, and this is a big deal. And the managed care plan, the county clinics, and the sheriff's office have already been working on this quite a bit. So then the other piece, so that capacity building program, so that funding, those have all kind of are done. So there were 3 rounds of funding opportunities. And again, it was the county behavioral health agencies, the county sheriff's offices, the county probation offices, and the California Department of Corrections and Rehabilitation. So, that's one less thing that you kind of have to worry about as you're thinking about what is CalAIM and can I, what's the CalAIM Path Initiative, and can I explain it to somebody? So then the other part of the Justice Involved Initiative was that planning and implementation. And I'm going a little bit out of sequence here, but it's for a reason. So there's this 90-day pre-release time frame that I kind of alluded to earlier, and that has been pushed back to October 1st of 2024 to allow time to ensure that that they get it right, and I really appreciate they're not kind of pulling the trigger like, we'll figure it out. It's like, we'll just build a plane while we're flying. No, they're making sure that everything is truly in place. And after talking through our learning sessions, talking to people who are providing services to those who are incarcerated, it is really complicated. For example, it may have taken years to get to the medication, the set of medications that keep somebody stable from a behavioral health standpoint. And then, you're going to release them. And how do we make sure that they have the medications once that there's not a gap in medications? That it's just so complicated. There's a policy and operation guide. It is 207 pages, but it is excellent. And if you want to learn more about this and what it might mean to the community and to supporting these individuals, this to me is just ginormous. And I'm unsure how other states are handling this, but it seems to me as though California is doing an amazing job. However, so that 90-day pre-release part, that is going to only start October 1, 2024, and it's going to be phased over 2 years. But it provides a lot of additional kind of services and care. Services, I'm trying hard not to use that care word. But January 1, so right around the corner, there's the go live for the Justice Involved Population of Focus. And so a couple of important points. Well, one most important point is that individuals may still qualify for the population of focus, even if they did not receive pre-release services. So we don't want to release people January 1 and say, well, you can't have ECM because you haven't had that 90. That doesn't make sense. So managed care plans are also going to have to update their provider directories to include the enhanced care management provider network. So I can see that there are some things in chat. Berenice, I'm going to ask you if there's anything in there that we/all of us can address right this moment.
I think so, Trudy. Ari was just providing more resources on the question that was submitted earlier.
Awesome. Thank you, Arif. Okay. So we covered the Justice Involved Capacity Building Program. So not that bad, right? So we've kind of made it smaller and pushed it to the side. And then there's the other kind of aligned program and initiative. And we've broken that down into a 1, 2, 3, 4. So we're going to quickly go through the 1, 2, 3, 4. We're still on our journey to kind of break it down. So this one's easy peasy. So the whole person care services and transition to managed care mitigation initiative. It was actually the first of the 4 coordinated path initiatives to launch in 2022, which, I don't think that was very much on my radar. I don't know about the folks here, but it's kind of a transition from the whole person pilot. So you don't even have to worry about that anymore. Okay, so one less thing to worry about. Then the second one is the Technical Assistance TA Initiative, which we affectionately know as the TA Marketplace. This is funding that is provided by DHCS for providers, CBOs, counties and others to get technical assistance. And our ECM and community supports providers have been taking advantage of this. It's managed by PCG, our third-party administrator, and there are 7 domains. So there's building data capacity, community supports, engaging in CalAIM through Medi-Cal managed care, enhanced care management, promoting health equity, supporting cross-sector partnerships, and workforce. And HIP is a vendor, SkyO is a vendor, Intrepid Ascent is a vendor. I mentioned them because they do have one of their, the county has engaged them for a couple of projects. Katie Maeda is on there. What we've heard from our folks that are applying for TA Marketplace funding is that they prefer to interact with folks who are local to them. No big surprise in Santa Cruz County. So TA recipient, you have to, so the process has been a bit of a bear, that you have to submit a TA recipient eligibility application so you are deemed okay to apply. That is pretty easy peasy, and we've gotten on Zooms and done screen sharing and helped with filling those out, and been surprised, like, oh, I need to find my mission statement. So we're Googling like mad to find it and, plug it into the application. So then once you are deemed eligible to be an applicant, then you have to let DHCS and PCG know just a little bit about what is the project that you're proposing. And then usually you work with your TA Marketplace vendor to develop a scope of work. There are off-the-shelf products. The process seems to be much quicker for off-the-shelf. The hands-on, you have to kind of really have a proposal and a scope of work built out, and it seems to take a little bit longer. We know that because we've worked with an ECM provider to provide a hands-on product. I actually think it should have been off the shelf, but lesson learned. And then soon we're going to have kind of self-service. And if we have time, we'll take a look at what that looks like. Okay, so remember we had 4, we're up to number 3. So the collaborative planning and implementation initiative, that's us. So those are regional path collaboratives. So we kind of figure out how to support implementing ECM and community supports. There are 10 facilitators covering 26 regions. It's managed by the Public Consulting Group. They're a great team to partner with. We meet with them at least once a month. Well, we meet one-on-one with them. We tell them what we're doing. They give us kind of coaching, which has been really, really helpful. And we've been the Health Improvement Partnership of Santa Cruz County has been the facilitator for the Santa Cruz County Path Collaborative in 2023 and 2024. Of all of that, we are unique. We have only one region, and we're actually in the county that we serve. We'll talk a little bit more about this tomorrow. And then there's, if you want to join a collaborative, you have to register to participate. And this is how DHCS and PCG keep track of, and HIP actually, because we have like a master distribution list. We keep track of who is kind of in the collaborative. And if you want, you can go do it now and take a look at it. For example, you may want to join the Path Collab that covers Merced or Monterey, which is Camden Coalition. We consider them our sibling path facilitator because we share the same managed care plans, Kaiser and the Alliance. So you can register for as many as you like. All right, we're on to the 4th out of the 4. The capacity and infrastructure transition, expansion, and development is such a mouthful. I'm so glad that they have the acronym, the CITED initiative, and that is really to support the delivery of ECM and community supports. There are several entities that can qualify. We have already gone through round 1A, round 1B, and round 2. And I just want to point out again, like how much funding is being provided. I mean, it's just staggering to me. 352 million the DHCS cited website has all kinds of details, eligibility, allowable uses of funds. For people who are nosy parkers and want to see who got how much money, you know, you can actually dig and find out. That is an option as well. Our cited two funding recipients in Santa Cruz County are the following. I will say, no, I'm not gonna go back. I forgot to say something about the TA marketplace, but I think you guys are fine not knowing. But so for cited, the TA marketplace are maybe smaller amounts of money that are allocated, and DHCS has set kind of caps for how much TA marketplace funding they will allocate per county. We don't know what those amounts are. We don't know how close we are, but you know, if one county is getting a ton of TA marketplace funding, you know, we may see that, although I doubt it, because it's so hard to actually get that funding, I feel, at this point. You know, they pay attention kind of to where the allocation is. So kind of making sure that the distribution of funds is equitable. We do know that even among our ECM and community supports providers, that it's a little bit unequitable for the distribution of funds. So for example, if an organization doesn't have a dedicated person who can go out and look for and apply for the funding, you know, they're at a disadvantage, unfortunately. So, and it's, like I said, it's big money. So so 144 million to 145 organizations and providers. If you do the math, if we were to divide it just, you know, evenly among the 145, that's like about $1 million to each person who received that funding. So I'm going to unshare for a second, and I'm going to try to bring up the TA marketplace and share again, and just want to kind of open it up for questions, comments, before we move forward. I cannot see chat, so if someone can help me out, if there's anything in chat or a hand raised, that would be really helpful.
Judy, there's a hand raised. Doug?
Hi, sorry, my questions are a little more granular, but thanks for the overview. It was very informative. You know, we started off with the path and went into that a little bit more with the incarcerated release of people with medical needs. Is there going to be some oversight into that transition of care? Because we have very stringent guidelines from like transition of care from the hospital or the skilled nursing facility to the home or the home health. But is there going to be and making sure that that network provider is engaged with that patient is upon discharge? Is there going to be a similar fashion with the prison? I would think certain criteria like those taking insulin daily or those taking very strong behavioral health medications that will be at risk of being hospitalized should they not stay balanced. Those I would think would need some kit hand, you know, holding with that transition.
That is a great question, Doug. And I think if you take a look at, and you know, when we send the slides out, you can probably Google it on your own and find it pretty quickly. But that 207-page document that I said was excellent. I read through that. I tend to be a fast reader. Not everyone probably wants to read that entire document, but I read through it, and the care that has been taken to address exactly those things, Doug, is, in my opinion, as I read it, phenomenal. Like every, when it comes to those transitions of care, every T is crossed, every I is dotted in that document. in the reality, you know, you know what happens, you know, people fall through the cracks, they disappear, you know, we can't get them back into the network of care. But if you take a look at that document, Doug, I think you will be impressed with how comprehensive and careful DHCS has been as they design this kind of additional health system option.
Yeah, I mean, I
Yeah.
agree with you 100%, and I have read through some of it, and just like I was reading through Senate Bill 1004 and the all plan letter when I was with Apollo Medical Holdings, formerly Network Medical Management, to implement that for our palliative special group that we had, because I did informatics on anybody that qualified. So that, the reality is that they have the guidelines, and then you have to show compliance to those when you get audited. But in the truth of the matter is, that network I was with, we had 1,000 doctors. And so when you get 1,000 primary care and 7,000 specialists, 8,000 doctors in total, that's a lot of informational type of things. And we can bring them all together with our provider portal and ask them to log in and look up every patient here for eligibility. And then we try to guide them through these things. But it becomes insurmountable with large things. I'm glad the state is taking a community approach. And I think that should be the narrative of anything we do with healthcare. It should be a smaller community approach, because that's going to be more accurate and more quality intensive. But when you deal with the big blues and I was with Molina for 8 years with the big Molinas and stuff like that, it's tough. It's tough to administer that type of implementation across that large of a network. And then those patients do fall through the cracks. So as a registered nurse and a case manager for my entire career, I just hope that we can get some involvement from people that know what they're doing and it could help other people to learn what to do.
Agreed. So good point, Doug. And I will say that, our managed care plans that we work with have been so involved. So the Central California Alliance for Health has been, or the Alliance has been, like, we talked to the other, so there are, 10 other facilitators, and they struggle with their managed care plans. Like, we in Santa Cruz County, at the very least, have like lines of contact to them. They meet with us on a monthly basis. They have the office hours, which not all of the managed care plans do. They have just been amazing. And Kaiser is new to our county, but thus far, by all indications, like, they are going to be as accessible, as careful, as the Alliance. So I think that is kind of, I can't speak to the rest of the state. I understand your concern, but I do think that in Santa Cruz County, we are incredibly fortunate.
I agree. I've been to several of your meetings. I try to go to meetings across the board my practices that I work directly with are in Los Angeles and San Diego County, but the patients could live anywhere in California, and we can provide our virtual care management programs to them anywhere. So that's why I attend all of them.
Right.
But who is it? Chavez, the one who leads the Santa Cruz group. He's amazing. I think he does a great job.
Yeah, Skyo. Yep. So here's what the TE marketplace looks like. You can see that it is, there are a lot of vendors. You can sort by off the shelf. You can sort by hands-on. Here are the 7 domains that we mentioned. So I keep looking at promoting health equity, because I feel like it's really important. And I always notice that we have the fewest vendors around health equity, but this is This is where you go to kind of see what's available, and you can view the vendor profile. You can just look at, let me see if I load. You can see like this blue here. This is what they offer. So project management services and mentorship, MIPS reporting support. Not really sure how that's related to ECM and community supports, but yet, you know, there's Intrepid Ascent. You know, they have been doing surveys. They've been working with the county to understand kind of the data capture and the systems that we're using. I think I mentioned Katie Maeda. The county has worked with Katie, and another one of our community supports providers is going to work with her. But there's so much available here that, you know, I really wish that people would take advantage of if possible. By now, you should have seen a Zoom poll. We don't want to send out ginormous surveys on how we're doing. We really just want to know, did you learn something new today? Was this not a waste of time for you? We don't want to waste your time. Oh my goodness, like how many meetings? And basically, what could we have done better? So this is our kind of not fussy survey. We want you to let us know. We truly believe that feedback is the special sauce when it comes to building skill. And so we want to be sure that we get feedback from you. And then this is, once you fill out the Zoom poll, I'm going to call this a wrap for today. So we covered a lot. We kept it high level. And we look forward to continuing the journey with you tomorrow. Guess what? Same place, same time. And as I noted, we're going to take further define the role of the PATH collaboratives tomorrow. And we're really looking forward to sharing some of that with you. And if possible, if we have the opportunity to hear like what else you would like in 2024, you know, that's fantastic. But then I'm also really looking forward to December 6th, where we are going to tie everything together really around our county and kind of what we've learned. So we met with an ECM provider this morning, and we said, what can we do better? And they didn't actually tell us what we could do better. They told us what they liked we're doing. And one of the things is that we share with all of our ECM and community supports providers, well, so-and-so is doing this thing. Well, so-and-so is doing that. Well, so-and-so is doing this measure. Here are the platforms that so-and-so is using. And so kind of letting people know what everyone else is doing and synthesizing, keeping our ear to the ground about what's coming, those kinds of things. So we look forward to seeing you tomorrow and continuing with our journey on covering CalAIM and PATH basics, especially in the context of our community. So thank you so much and have a marvelous day.
Thank you.